Good evening, everyone, and welcome to another edition of the National Fellow Online Lecture Series. This lecture series is sponsored by the AMSSM Online Fellows Education Subcommittee, as well as the AMSSM Education Committee and the Fellowship Committee. So this program is meant to serve as an adjunct to your fellowship trainings already educational program, and it's meant to provide fellows with direct access to educational experience with experienced AMSSM members, and at times invited guest experts in a variety of formats. And mainly it's used for assisting in CAQ preparation. Just a few housekeeping tips. Please mute your device's microphone and turn off your video to optimize performance. You can submit questions through the chat, and we will go over those at the end. You're welcome to include your name and program if you wish, but you do not have to. And then I will moderate the questions at the end of the program as time allows. And then as well, towards the end of the lecture, there will be a link posted with the evaluation. Please fill this out. This helps us determine what content you guys would like to see in the future. So tonight, we're going to talk about the non-surgical management of elbow pain in throwers. And we are very lucky to have Dr. Robbie Bowers, who's going to be speaking with us tonight. Dr. Bowers is a sports medicine physician at Emory Sports Medicine. Prior to medicine, he played Division I college baseball at Furman and received his PhD in exercise physiology from Auburn University. He completed his residency in physical medicine and rehab at Emory University, and then later was where he served as a chief resident before completing his sports medicine fellowship there as well. Dr. Bowers has served as the co-chair of the Fellows Online Lecture Series subcommittee for the past 2 years, and he currently serves as a team physician for the Atlanta Braves, Georgia Tech Baseball, and the College Park Skyhawks of the NBA G League. As a former collegiate baseball player at Furman, Dr. Bowers has a particular interest and expertise in the care of the overhead athlete and serves as a director of Emory Baseball Medicine Program. So without further ado, I will turn it over to Dr. Bowers.
Thanks, James. I appreciate it. Get my slides up. Okay. Should be good to go there, right? Good.
Yep, you're good. I can see your slides.
Okay. 1 second here. Okay. So thanks everyone for tuning in tonight and for having me. I appreciate it, the opportunity to speak on this topic that I'm really passionate about overall. And then, as co-chair of this subcommittee for the last couple of years, regardless of this talk tonight, hopefully all the fellows out there or anyone that's preparing for upcoming sports medicine board exams have found the series helpful and helped with preparation. The committee works hard to make sure we get good speakers and good topics, and so hopefully everyone is finding these lectures very helpful. So with that said, we'll start the topic for tonight. And so it's titled Non-Surgical Management of Medial Elbow Pain in Throwing Athletes. But we're not just going to focus on the pathology itself. We'll talk a little bit about injury risk factors, not an exhaustive list by any means, injury risk factors, then some more specific to medial elbow pathology and the non-surgical management. I may mention surgery a little bit here and there, but it'll primarily be focused on the non-surgical management. And then we'll talk a little bit about rehab concepts at the end. I'm certainly not a physical therapist and not an expert on the rehab side, but I've spoken to a lot of physical therapists, and some of them put some slides together for me as far as the goals of what we should do from a rehabilitation standpoint, which certainly fits into the non-surgical management side of things. All right, so I've no disclosures. Some of the slides in this presentation come from Jason Zrimsky and Peter Kriz, who I've been really lucky to work with on some projects here over the last several years. So we have a baseball medicine program at Emory. I just put this here because there are some resources on our baseball medicine page, like an arm care handout, things like that. somehow this site got shut down and restarted. So I think some things got lost in the fray. So hopefully all the stuff that I had on there previously is back up now. But there's some resources there for anybody that needs them if you need athlete handouts or anything like that. So beyond that, all of these pathologies that I'm going to talk about today will be thoroughly covered in this paper. So this invited review, we submitted it for publication last month, and it should be coming out here within the next couple months. And it'll thoroughly cover all elbow pathology in throwing athletes, so not just medial. So anything that I leave out, it will cover that as well. So just be on the lookout for that. There'll be one on throwing injuries as well in the same issue, or there should be at least. Throwing it, I meant shoulder injuries, not throwing. So to start off, we want to know, why do these players get hurt? And so this is a figure that Jason Zaremski and his team put together a couple of years ago, and just an elegant figure to allow you to easily digest why these players are getting injured. And so we have these natural and kind of developmental risk factors that will predispose a throwing athlete to injury. And then you add in the exposure to these extrinsic risk factors that we talk about a lot in this world, such as sports specialization, volume and workload, throwing velocity, and just overuse in general. And that creates this susceptible throwing athlete, but then you have this inciting event, which leads to injury. So why does the injury cycle start? So as we go all the way through from youth to pro, that injury cycle starts when these kids are young. So youth and pre-high school. So high school, when they start to develop power, they start to get to the point of skeletally maturing. Once you get to that point, if you haven't kind of honed things in on the youth and pre-high school kind of adolescent level, then you're going to be in for a rough go from an injury standpoint. So all that is to say, we want to teach proper throwing mechanics at a younger age before these kids develop the power that they're going to develop as they get older and more skeletally mature, in order to provide some sort of injury prevention. Because if they have bad mechanics, then develop power, it puts a lot of stress on the throwing arm, and will predispose them to injury. So we need to focus on mechanics even when kids are very young. So beyond the mechanical part, what else can lead us to injury? So like I'd mentioned before, we're not going to talk about an exhaustive list of risk factors, because there is a broad list of risk factors. I'm going to focus more here a little bit on velocity. And so we know that increased pitch velocity leads to increased elbow pain as well as increased elbow injury risk. So this study here is in elementary school players. So we're talking about kids that are just 12 years old with a range of 9 to 12 years. And as we see their pitch velocity increase, we also see increased risk of medial epicondyle abnormality and medial elbow pain by a factor of 3 times. And so we see here, even in the young kids, pitch velocity leads to increased elbow pain and injury. Then when we look more on the professional side, we see the same thing. So pitch velocity is a predictor for medial elbow pain and ulnar collateral ligament injuries. And it's one of the most well-established risk factors, and it's probably the primary risk factor at this point. So we have asked the question now, like, why we have all of this data, and why do we continue to see an increase in these UCL injuries and UCL reconstructions? And what we see along with this continued rise in these surgeries is also a continued rise in pitch velocity. So if we look at these 100-mile-an-hour pitchers thrown in the MLB, 2008, we had less than 500. In 2023, we had over 3,500. And so guys are just throwing a lot harder now, and that predisposes them to injury. So we see a study here from Peter Chalmers, who's great with baseball medicine out in Utah and publishes a lot. And so their paper in 2016 in AJSM, they looked at professional pitchers 2007 to 2015, and they examined the number of UCL reconstructions, and peak pitch velocity was the primary independent risk factor for whether a pitcher underwent UCL reconstruction. And so that's a big deal, and tells us kind of the primary risk factor is velocity. We have some secondary risk factors as well. Interesting though, where that pitch counts were not a significant predictor for UCLR in this study. So why are guys throwing harder now, or what are guys doing in order to try to throw harder, which could be playing a role in this? And certainly these weighted ball velocity programs are playing a role. I gave a more extensive talk just on this particular topic at the AMSSM meeting last year, and these are two reviews that have been done recently that kind of thoroughly go through the literature that's out there on weighted ball programs. So if you're interested, these two reviews are helpful. And so what we see when we take this table from the Caldwell paper is that if you look at all of these studies that have been done on weighted ball programs and look at the results, primarily velocity increases in every single one of them. And we see lower velocity increases at 2 miles an hour, all the way up to velocity increases of some of the ones that were done years ago of 11 and 9 miles per hour. So this is probably the best weighted ball study that's out there, in my opinion. I mean, there's been no awards or anyone a consensus on this, but in my opinion, it's the best one. Mike Reinhold, who's a great physical therapist up in the Boston area that publishes a lot in this realm. They looked at weighted ball velocity programs. And so they had two groups. One group just threw the regulation 5-ounce baseball. Then you had a weighted ball group who did a 6-week weighted ball program. And after that program, we see a 2.2 mile per hour increase in the weighted ball groups just after 6 weeks, 2 miles per hour increased velocity on their fastball. And interestingly, we also see an increase in shoulder external rotation range of motion. So when they're in this layback phase, they're getting more external rotation with their arm abducted at 90 degrees. And so increased fastball velocity, increased shoulder external rotation. Interestingly, there was no change in strength in the weighted ball group, and there was no change in arm speed in the weighted ball group. So that tells us that the increase in velocity that we see is not due to speed of the arm or strength of the arm. So something else is leading to this increased velocity. However, we also see in the weighted ball group was a 24% injury risk. So you see we had in these athletes 2 olecranon stress fractures, a partial UCL tear, and a complete UCL rupture. There were no injuries in the control group. So it seems based on this data that weighted ball programs will increase velocity, but they also increase injury risk. Interestingly, so this is a different study, and I'm just throwing this in there. It's a little bit of a tangent. But if you look at this study from Brandon Erickson up in the Philadelphia area, they looked at lighter baseballs and training with lighter baseballs compared with standard 5-ounce baseballs, and they did not use weighted balls. So what they found with training with the lighter baseballs is that fastball velocity increased by 4.8 miles per hour. Now, this was a 15-week program, not a 6-week program. So maybe at 6 weeks, it only is going to increase 2 miles an hour, as well as the last one with weighted balls. But you see fastball velocity increases, and there were no associated injuries. So I often will guide athletes or parents that ask me the question about weighted balls and increasing velocity. If they ask me this question, I frequently will guide them towards this study and say, hey, look, these lighter ball programs can increase velocity and don't seem to have the injury risk that weighted balls do, but have to keep in mind, as I put down there at the bottom, the increased velocity in and of itself leads to increased injury risk. It's just building off of Mike Reynolds' last paper. They did a follow-up where they looked at high school players, and they're really looking to see what are the changes we see with weighted ball programs apart from velocity. And so they used underload balls, overload balls, and then extreme overload balls. And they did passive range of motion before and after each throwing session with these balls. We saw no difference in shoulder external range of motion with the underload balls, a 3.3 degree kind of moderate increase with the overload balls, and a significant increase with the extreme overload balls. And so really the take home here is that this increased shoulder external range of motion may be the explanation for why we're seeing increased velocity and also increased injury rates from these throwing weighted balls. And so really putting it all together, how is pitch velocity increased by weighted ball velocity programs? It's not a change in arm strength or arm speed. It's our best guess at this point is it's rapid increase in shoulder external range of motion. So shoulder external rotation range of motion increases, and then this in turn increases pitch velocity and also increases shoulder and elbow forces, leading to increased injury risk. So this figure Jason Ramsey put this together. So I'm just going to go through and kind of put it all up here to get through it. So what we're looking at here is use of weighted balls. We see increased shoulder external rotation range of motion. This will lead to increased pitch velocity while at the same time increasing shoulder and elbow forces. And those two things together, the increased velocity and the increased shoulder and elbow forces, in turn lead to increased injury risk so weighted balls essentially are leading to increased injury risk from two different paths. So this is just a plug for a recent editorial that was in CJSM, where we kind of talk through some of the reasons why with our pitching restriction policies that we have more in kind of adolescent and high school players, why, even though these policies are in place, or we continue to see increasing injury rates. And we see from the table here, we make some recommendations of how we may try to reduce these throwing injuries, but there's certainly a lot of work behind just these recommendations. But I think that this paper is a nice discussion of why we continue to see these injury rates increase despite our attempts up to this point. See if I can get the slide to advance. I should say I'm just glad that Dr. Kriz and Dr. Zrimsky kind of let me tag along and steal some of their shine on this. They're the brains behind the operation. All right, so that was just a little bit of background. I want to talk about some of the kind of hot topics that are out there right now as far as throwing athletes are concerned, and why we're continuing to see increased injuries. Now, again, as I mentioned, that was not an exhaustive list. It kind of focused more on velocity and weighted balls, but that certainly is a component of why we're seeing injury rates continue to increase despite other efforts that we're making to try to reduce injury risk. Now, these are the ones that we're going to discuss today as far as medial elbow injuries. We'll talk about Little League elbow, medial epicondyle avulsion fractures, posterior medial impingement, flexor pronator mass injuries, ulnar neuritis, and UCL sprain and tear. There's some lateral and posterior injuries that are common to throwing athletes that we're not going to discuss because they're in a different area of the elbow, and it's probably just too much to discuss at one time here. There'll be Panner's disease, OCD of the capitellum, and then also olecranon on bone stress injury and fracture. And I see a lot of throwing athletes, and so I see a lot of olecranon on bone stress injuries. I think in just a normal day-to-day sports medicine clinic, maybe you don't see that as much, especially as a fellow. Maybe you don't see the olecranon stress injuries, but you see more throwing athletes. Those are very specific to throwing athletes and can be a common reason why they have pain. I end up getting a number of college guys or high school guys every year, I feel like, have these olecranon bone stress injuries. So that is a common injury that you'll see specific to throwers, and something to certainly be aware of and know how to treat. So the anatomy that we'll focus on here from a soft tissue standpoint, we have the flexor pronator mass and the medial epicondyle that's here, that's kind of laying on top of everything. You peel all that off, and you're going to come down here and see the ulnar collateral ligament. So in a thrower, what we're primarily going to be talking about is the anterior bundle of the ulnar collateral ligament. The posterior bundle and the transverse or oblique bundle, they don't do as much. Kind of when you get deflection beyond 90 degrees, which you don't see a lot with throwers, when you get deflection of your elbow beyond 90 degrees, the anterior bundle kind of, its role drops down a bit and the posterior bundle takes over. But when you've got your arm kind of more in a throwing position right here, the anterior bundle is what's taken most of that valgus stress that's placed on the elbow. So that's typically the bundle of the UCL that we're going to see injury. And then we just see the ulnar nerve that's kind of outlined that runs along this area too. So just as you can think that a valgus stress on the elbow can injure this anterior bundle, valgus stress on the elbow can also irritate the ulnar nerve, leading to ulnar neuritis. So forces on the elbow, we want to understand this before we really talk about elbow injury. So during the late cocking, acceleration, deceleration phase of throwing, and so late cocking as you kind of come into max external rotation, acceleration leading until you release the ball, and then deceleration where you reach maximum extension or kind of banging your elbow there. And so we have three different forces that are kind of acting on the elbow at that time. So we have tensile stress, which is that tension and valgus stress along the medial aspect of the elbow that's going to put some stretch on the UCL, the flexor pronator mass. And then in kids, the medial epicondyle, where they're going to tug at the medial epicondyle growth plate there in kids. you can get an medial epicondyle avulsion. And then in adults, you have more of that flexor pronator mass that's right there that you can injure. At the same time, you're going to get compressive forces at the lateral aspect of the elbow. And we'll see this in some figures that I have in a little bit. So that compression kind of at that radiocapitellar joint, as you get valgus stress on the medial portion of the elbow, you're going to get compressive forces on the lateral aspect of the elbow, and that can affect that radiocapitellar joint. And then at the same time, as you're coming into extension with the arm, you're going to get a shearing stress at the posterior compartment where the olecranon is kind of going into the trochlea there and causing a shearing stress, which can lead to joint degeneration and osteophyte formation and those sorts of things. So those are the three forces. And so those forces indicate kind of the injuries that we'll see at these different locations in the elbow and a thrower. First one to talk about Little League elbow. Primarily, we're going to talk about Little League elbow from a standpoint of medial epicondyle apophysitis, so injury to the medial epicondyle growth plate due to tension or valgus stress. This is going to be primarily, you'll see in 9 to 14-year-olds, maybe most common kind of your 12 to 14-year-olds have an insidious onset of pain over the medial elbow as a result of just repetitive stress from throwing. So, we see this now in these kids that are only playing baseball at a young age. They're throwing year round, and it's just an overuse injury and just a tugging at that medial epicondyle growth plate. So they'll begin to have pain, and that likely kind of progressively worsens with time until the point where they feel like we need to get this evaluated. So on exam, you're going to have pain directly over the medial epicondyle. A lot of times they'll lose full elbow extension because it hurts them there, and they'll definitely have pain with valgus stress. So your physical exams for valgus stress can be milking maneuver, where you just put some valgus stress on the elbow and then moving valgus stress. You put some valgus stress on the elbow, you kind of milk them, and then you move them into flexion and extension. And that moving valgus stress test is kind of your money test as far as medial elbow pain, UCL, and getting some tug at the medial epicondyle in a youth athlete. So I should say here, in a kid, and I think a lot of us know this, the bone is not quite as strong as the soft tissues. And so in a kid, you're likely in a 9-year-old not going to see a UCL tear. If they have something that would mirror a UCL tear, you're going to have a medial epicondyle avulsion. So that's what you're going to look for in kids, is more of those injuries. If a kid, 9-year-old, comes in with medial elbow pain, you're thinking Little League elbow, medial epicondyle avulsion. If they have an acute injury, you're not really thinking UCL injuries at that time. So treatment is going to be rest. And I tell parents this all the time. I mean, if you look at the up-to-date article on Little League elbow, they say rest is a 4 to 6 week period. I typically find 4 to 6 weeks is not long enough in these kids. Usually it has to be a little bit longer, but frequently with parents and these kids, you have to bargain with them. And so I'll tell them, okay, we're going to do 4 to 6 weeks first. We'll start to try to throw a little bit at that time. If they have any pain at all, we're pulling back and we're taking another month off. And so you have to bargain with them a little bit. If parents are really with it and they're not pushy and they say, hey, we're not going to throw for 2 to 3 months, then I'm happy with that as well, because it makes it easier on the front end. If 3 months is too long, I mean, it's not going to hurt anything by waiting 3 months to throw again. And so we can use NSAIDs here. You definitely don't have to. And then PT eventually with the interval throwing program. And so we'll talk about some of the PT components of this a little bit later. Medial epicondyle avulsion fracture. So one key component of this, and any time a youth athlete comes in with medial elbow pain, a youth throwing athlete, and you're going to get x-rays, you're immediately thinking medial epicondyle growth plate or avulsion fracture. And what you want to do is you always want to get bilateral x-rays for comparison. So don't just get the side that hurts, get the other side, because that way it'll show you if there's any sort of gapping of that medial epicondyle growth plate here. So we see this on the right side versus the left side, a little bit of gapping. And you may not call that gapping if you see that alone without the comparison to the other side. So always remember in these kids, get bilateral elbow x-rays so that you can compare. So the medial epicondyle avulsion fractures are going to be more of an acute onset as opposed to an insidious onset with Little League elbow. And so risk factor for this, pitching through Little League elbow, you have this lower level pain, it's bugging them, and then you can have one acute injury where you pop the medial epicondyle off. And so this is is the same kind of impulse that's going to create a UCL tear in an adult. In a kid, medial epicondyle avulsion fracture. So treatment, you really, what it comes down to at first is, are we going to treat this non-surgically or operatively? And this is going to depend on if there's significant fragment displacement here. So if you look at the textbooks, in a non-throwing athlete, anything under 5 millimeters, usually you can try to treat that without surgery. Now, in a throwing athlete, because of the unique kind of valgus stress you're placing on the area, anything even 2 to 3 millimeters of displacement, I still will send those to the surgeon to kind of get their blessing of, hey, we can treat this non-surgically, because I'm a lot more conservative with these. And I typically I'm only seeing these in throwing athletes. So even with just minimal displacement, 2 to 3 millimeters, I'm still sending you to a surgeon just to make sure we're doing right by the kid. So in a throwing athlete, typically 3 to 5 millimeters of displacement, they're going down the surgery route. But I've been surprised. I've sent a surgeon before, and a kid's had 3 millimeters, 4 millimeters of displacement, and they've decided to treat them non-surgically and cast them, and the kids have done well. So it's not a hard and fast rule, but just be really conservative with these in a thrower and send to a surgeon, kind of err on the side of caution when you see any sort of displacement. So you're not up, you're gonna have brace and cast for 4 to 6 weeks. You can, if they're in a brace, they can come out of the brace and just do some light range of motion, but they're in the brace all the time. Otherwise, a lot of times, if there's any displacement, we'll cast these kids for 4 to 6 weeks. And then after they get out of the cast, start PT and a throwing program after we see healing on imaging. But there's really not going to be any throwing for at least 3 months after one of these injuries. And so, like I mentioned before, throwing athletes are going to place high distraction forces on the medial elbow. And so we just need to be conservative and send them for surgical consultation if there's any significant amount of displacement, because these are just injuries you don't want to mess around with. So I'm very conservative with them. All right, so next one, we've got a posterior medial elbow impingement. And so this is a paper, we wrote a review paper on this in 2022 and current reviews in musculoskeletal medicine, a couple of my colleagues with the Braves. And so this paper was published, and then we took and kind of made it more of a longer form, and it's going to be a book chapter in the upcoming edition of Maury's The Elbow and Its Disorders. And so kind of the big elbow textbook. And so the 6th edition should be out soon, and this will be in there as well. But this is an easy kind of read through that's out there right now. It should be open access and free to get access to. So with posterior medial elbow impingement, and a lot of times with this, you'll hear valgus extension overload syndrome. This is kind of a subset of valgus extension overload syndrome. So valgus extension overload syndrome, it combines all of these things. So you have valgus stress on the medial elbow, the extension component, which is going to give you your posterior symptoms, and then all of it together with the kind of the lateral, you'll see the lateral joint at the radiocapitellar joint with those compressive forces that you'll see there. So when you hear valgus extension overload syndrome, it's kind of an all-encompassing term. The posterior medial elbow impingement is kind of that shearing stress posterior component of all of this with the forces that we see at the elbow. So presentation here in physical exam, kids or athletes that have this are going to have pain. They may feel some catching if they have a couple little loose bodies that are in the joint. So pain, catching. They'll have crepitus. They'll feel their pain posteriorly, maybe a little bit more medially, but it's not going to be over the medial elbow, kind of where the UCL and the medial epicondyle is, kind of be posterior medial. And they're all going to, usually they won't have a ton of pain with valgus stress. They maybe have a little bit of discomfort, but their primary pain is going to be when you bang them into extension. And so they may have pain with just regular extension, but then if you do a bounce test and kind of bounce them into extension, that's really going to bother these guys. And then, so this can also be associated with cubital tunnel syndrome and ulnar neuritis, because as you develop some osteophytes of that posterior medial component around the olecranon, those osteophytes can kind of rub on the ulnar nerve and cause some secondary ulnar neuritis. So that frequently will come along with some posterior medial impingement symptoms. So treatment for this is primarily going to be non-operative. So you're going to have rest, cessation from throwing, just like we talked about before, NSAIDs. You can consider doing an injection if the joint seems really irritated and inflamed. You can put some anti-inflammatory with either Toradol or some corticosteroid. I do not love putting corticosteroid in a joint of a thrower because that can, just like we see with an arthrogram for an elbow, when you put dye in there, that we put the dye in so that it can leak around the UCL and we can see what's going on. And so I do not like putting corticosteroid in the elbow of a thrower because I don't want any steroid around the UCL. So that's just kind of my, I'm not sure you read that in a textbook, but that is how I feel about it personally. So they'll go into PT, and again, they'll refrain from throwing at first, usually 4 to 6 weeks. During that time where they're not throwing and doing sport-specific activities, we're working on mechanics, working on the kinetic chain, and then after they progress through that, then we'll start a throwing program. Now, the refractory cases or cases that maybe have massive, big old osteophytes or loose bodies in there, those may go to surgery more readily. And so you can either have open or arthroscopic resection of these osteophytes and removal of loose bodies. But the thing to keep in mind with surgery, and what a lot of the elbow surgeons that take care of a lot of baseball players will tell you, you got to be really careful with these surgeries because those osteophytes that have developed, those have created some stability for the elbow. And if you go in there surgically and you cut all those osteophytes out and you remove some of that stability, you're putting a lot more stress on the medial elbow. You're going to create more valgus stress and more valgus instability. And so you're setting them up for a medial elbow injury if you take out too much of that osteophyte. So there's kind of an intricate balance that you have to kind of toe the line when you're doing surgery for these cases. Next, and we just have a couple more, and we'll talk about a couple rehab concepts and then get this done. So flexor pronator injury strains. And so this is a good study done 2018 in AJSM, and they evaluated the flexor forearm injuries in Major League Baseball players. We found it was more prominent in pitchers, and these are not insignificant injuries. So a flexor pronator injury or just a strain of these muscles, they do 117 days on the IL for MLB players and 93.9 days for minor league players. Typically, we are a little bit more conservative with the MLB guys. And leading up to all of these flexor forearm injuries, pitching performance declined in all categories leading up to the injury. So you'll start to see a decline in pitching performance leading up to it. And interestingly, after forearm flexor injuries, the rate of subsequent injury increased versus those who did not have forearm flexor injuries. And so after you get a forearm flexor injury, you're at greater risk for further injury of that elbow. So that's why, even though it may be a grade 1 strain of the flexor pronator mass, you have to be really conservative with them, knowing that it could be a harbinger for things to come as far as further elbow injury, including UCL tears. So treatment, non-operative, and I got this from one of the Braves PTs, and this is really, kind of how we go through and treat these guys on the non-surgical, from the non-surgical standpoint. So you can consider doing a PRP injection. So if it's primarily tendon, you can put PRP into the tendon just to get some healthy cells in there to try to augment the healing process. So you can do PRP there. If it's more of a muscular injury in the flexor pronator mass, and we don't have to get into this now, but if you look at the data, platelet poor plasma seems to be more healing for muscular injuries. And so you can do platelet poor plasma into the muscle injury to try to augment healing of the muscle there. They're not going to throw for 6 weeks at least. They're going to go through their PT, work on kinetic chain and mechanics, and look for any kind of biomechanical deficits that they might have or strength deficits. So we see here 0 to 2 weeks, you're managing symptoms. You start working on strength at 2 to 4 weeks. 4 to 6 weeks, you then introduce some plyos. And after 6 weeks, you start the interval throwing program. This is a loose timeline. And I think what you'll see with rehab is rehab for each guy is individualized, especially when you get to the pro level. And so you can't just look at the calendar and say, okay, it's been 4 weeks, we can start this. You have to go by, each individual player. And so a surgery for this, and so that's why I put the picture of Dustin May, which is the crazy red-haired guy right here. So he was put on the IL in 2023 with a flexor forearm injury, and then eventually it just wasn't getting better. He had to have surgery with a flexor tendon repair, and then also a UCL reconstruction revision at the same time. So these flexor forearm injuries that require surgery, they're usually not going to be in isolation. Usually there's going to be a UCL injury as well. And so, like I said, more rare to happen in isolation. And then Max Fried, one of the Braves guys, had just, low grade flexor forearm injuries and was out for a lot of the year last year. And that's just, again, because you have to be conservative with these, because if you don't get them back to full strength and push them back too quickly, as we see from that study we talked about, these are an indicator of further elbow injury. So it puts them at high risk for further elbow injury if you don't give them enough time to get back. So ulnar nerve is the next one, or ulnar neuritis, and the initial presenting symptom for the ulnar nerve may be diminished performance rather than your typical nerve symptoms. It may not be the rip-roaring paresthesias right off the bat. They may just say, like, I don't have the control, I don't have the feel, maybe my arm feels a little bit dead, and just diminished performance. They may just have medial elbow pain. So I had a couple college guys last year that just had medial elbow pain. You get scans, their UCL looks fine, and you scan them with ultrasound, and they really isolate their pain right along the course of the nerve, but it's just pain. There's no paresthesias or other nerve symptoms there. So always keep that in mind. Initially, it'll recur with throwing only, and it's usually at that late cocking, early acceleration phase where you're putting high valgus stress through the elbow and it's stretching on the nerve, and they'll progress to having some symptoms at rest. One thing to keep in mind with the ulnar nerve is, do they have subluxation? Because if they have a symptomatic ulnar nerve with subluxation, that creates a different issue, and that those don't tend to do as well with non-surgical treatment and may require a transposition. But the issue with subluxation is also a very normal occurrence in the general population. And so, does the subluxation reproduce symptoms? It's a question you want to ask, because we see in the general population asymptomatic subluxation in 60% of individuals. And then this study out of Japan, they did dynamic ultrasound looking for ulnar nerve displacement, and they found in youth baseball players, a third of them had asymptomatic subluxation. So subluxation in and of itself isn't an indication that they need treatment or transposition. But if they have symptomatic ulnar neuritis or ulnar neuropathy and their nerve subluxes, it's an indication, at least what I've found, that they don't respond as well to non-surgical management. They're more likely to need a transposition. And then the diagnosis for ulnar nerve, often there's complication with other elbow pathology. So 42% of throwing athletes with UCL injuries have ulnar neuritis, and 53% of throwers with medial epicondylopathy also have some ulnar neuritis as well. Diagnostic tests for this. So even though it's second, I'll start with MRI. So MRI is not used to evaluate the nerve. It's used to evaluate for other pathology. And so you're not going to jump straight to the MRI and say, let's see what the nerve looks like, because frequently the nerve looks normal and you can't really tell, especially in a situation where it's just ulnar neuritis and irritation of the nerve. You can't really notice any abnormality. On ultrasound, we'll do nerve cross-sectional area measurements. But again, if it's just an ulnar neuritis situation, it's only been going on for a few weeks, so you're probably not going to have a big, massive nerve that you'll see in kind of these chronic conditions if you do a lot of these nerve measurements, like I do in the general population as well. And then also in ultrasound, you're looking at dynamic subluxation, because that's going to point you in certain directions as far as treatment as well. And so you put the probe right over the medial epicondyle, move them into flexion and extension, and see, as you move them into flexion, does that ulnar nerve pop over the medial epicondyle? EMG, nerve conduction study, may be normal until you get to more advanced stages. It can be 6 or 8 weeks before you see any abnormality on EMG. So that's all to say that in the early stages, a normal EMG does not rule out ulnar neuritis at all. So you have to keep an eye on their symptoms. I've found a lot of times they'll just isolate pain to the medial elbow. All their other structures are good. The pain's isolated right over the ulnar nerve, and you at times have to do a little diagnostic injection just to make sure you're in the right spot and headed in the right direction. So management, non-operative, 3 to 6 months before surgery is going to be considered. Again, rest from throwing, physical therapy. You can consider night splinting and an ultrasound guided injection. and you don't start a throwing program until you're asymptomatic. And the caveat, as I mentioned before, is going to be symptomatic subluxation. If they have symptomatic subluxation, I'm much quicker to send them to the surgeon or talk with the surgeon about whether or not this is something that requires a transposition. So surgery, if they have the failure of non-op treatment, persistent symptomatic instability, as I had mentioned before, they'll go to surgery. And so the preferred surgical technique for this, I'm not going to get into too much, it's going to be a decompression with a subcutaneous transposition. Decompression alone, if the nerve isn't already subluxing, it's going to predispose it to sublux if you decompress it. So you don't want to just do an in situ decompression. And then the submuscular transposition is kind of frowned upon in throwing athletes because you can get continued pinching of the nerve between the muscle as you continue to throw. And also, in order to bury the nerve under the muscle, you could do some damage to the flexor pronator mass with the surgery. So surgical options, decompression with subcutaneous transposition. So UCL injuries, this will be the last one that we talk about from an injury standpoint, are these UCL injuries. And so, as I mentioned before, we kind of already went through the anterior, the oblique or transverse, and posterior bands, and the anterior band is primarily the one that we're concerned with here. So Chris Ahmad, who's the head team doc for the Yankees, his team put out a good review on this topic back in 2021. We actually did a AMSSM Journal Club on it last year, I think around the same time. And they have a good table in their paper. I disagree with it in certain places, not to a great extent, but a few things. But it's a good table just to be able to reference for these injuries. And it tells you whether to pursue surgical versus non-surgical treatment for these UCL tears. And generally what we're going to see is that for the partial and proximal UCL tears, so more on the humeral side, those are going to be more amenable to non-surgical management. As you get the more advanced tears, complete grade 3 tears in the mid-substance, and really any tear at the distal aspect, you're going to think more surgery. And that's because when you look at the data, the distal tears near the sublime tubercle where it inserts down the ulna, the distal tears just do not do nearly as well with non-surgical management as the proximal tears do. And that's could be for a number of reasons. At the proximal aspect, they can have more support from the flexor pronator mass. There's better blood supply for healing. Those are some of the things that have been proposed as far as why the proximal tears do better with non-surgical management. So the question is, if you're going to pursue non-surgical management, do you do a PRP injection or do you not do a PRP injection? And I'll tell you off the bat, when I look through the data, and we published a paper on this last year, orthobiologic treatments for throwing athletes. When you look at the data, I think it just makes sense to do a PRP injection if you're going to pursue non-surgical management, especially in one of the higher level athletes, such as a college guy or a pro guy. In high school, I mean, you can talk about the pros and cons, but in the higher level kids, then I think it just makes sense, and it makes you more likely to be successful in non-surgical management. So this is a paper that frequently will be referenced and to kind of detract from PRP in these situations. And so this was AJSM 2019, looking at pro players that were treated non-operatively for UCL injuries that they either did or did not have a platelet-rich plasma injection. The group that did not, or that did have a PRP injection, overall, everyone together with PRP and non-PRP group, 54% return to play. So not great, kind of 50-50 with the non-op management. And the PRP group actually had a significantly longer return to throwing and return to play. But it's really, really difficult to make any conclusions from this paper because the only data you have is, did they have PRP or did they not? We don't have any information about the PRP itself, what was used, what was the injection technique, did they use any image guidance, what was the rehab afterwards? Like, it's just, did they have PRP or not? And that it can go so many different directions as you get into the kind of orthobiologics world of is it appropriate PRP based on cell counts? Do you use image guidance? Who's doing the injection? What's the rehab afterwards? So I feel like you cannot make really any conclusions from this paper at all. Now, even though this paper is 10 years old, it was in AJSM. I think it's the best kind of UCL PRP paper, in my opinion, out there. And I think in the future, it'd be great to have a randomized controlled trial with non-surgical management where you had a PRP group and a non-PRP group. But in higher level throwing athletes, it's just going to be hard to get people to consent to that because they're going to want the PRP if they're going to pursue non-surgical management just based on the return to play, and they're trying to get back to play quicker. So I just think a study like that's going to be tough, but it'd be great to have in the future. Here we see 34 overhead athletes with partial UCL tears. They got a single ultrasound guided PRP injection. 16 of these were baseball pitchers, 27 baseball players. The key here is they had already failed 2 months of rehab. So they did 2 months of physical therapy and tried to start a throwing program, and they had recurrent symptoms. So then they went back, they did a PRP injection, and this was an appropriate PRP. It was 60 milliliter blood draw with a 7.2 time baseline platelet concentration. And then they followed a standardized 12 to 14 week rehab protocol. And we see here 30 to 34 return to the previous level of play at 12 weeks. And that's what we'll see in a lot of these UCL PRP papers, is the average return to play is about 12 weeks or 3 months afterwards. One player did go on to surgery at 31 weeks post injection. But what we saw in ultrasound is significantly decreased medial elbow joint space opening on ultrasound with valgus stress, which is some confirmation for ligament healing as well. So I think this points to the fact that, these, because people will often ask, was it the rehab or was it the PRP? And I like this study in that they had already done the rehab for 2 months, were unable to return to play, went back, did the PRP and rehab afterwards, and they were able to get back to return to play after that. This is just another one. I won't belabor the point. OJSM in 2017. We see 25 throwing athletes here. They had grade 2 partial UCL tears for the most part, either at the proximal or distal aspect. They received 2 PRP injections 2 weeks apart. I'm still a 1 PRP injection guy. I don't think there's any data out in the literature that tells us, 2 or 3 is better than 1. They used a good PRP product of 5 to 6 times baseline concentration. A lot of times we're talking about concentrations now. We want to say how many platelets were injected in the billions, were there 5 billion, 6 billion, 7 billion platelets. But I just didn't go to the trouble to calculate that for this. So my fault on that. They followed a standard rehab program. 22 of the 23 athletes with primary injuries returned to play at an equal or higher level at around 12 weeks. Again, like I mentioned before, average return to play is about 12 weeks in these athletes. And then 20 of the 22 who did return to play had an MRI showing complete ligament healing. So this is a review that was done on this topic of players that had conservative treatment for partial ulnar collateral ligament tears in overhead athletes. And this was in the Journal of Sport Rehabilitation. And here's their clinical bottom line. I'm going to read this, and I highlighted it. So current evidence suggests that the addition of PRP to a conservative treatment program may improve outcomes in overhead athletes with partial UCL tears. Athletes whose treatment included PRP show higher return to competition rates and shorter recovery times before returning to competition compared with athletes who performed rehabilitation only. Additionally, athletes with grade 1 and proximal base grade 2 injuries return to competition rates comparable with athletes undergoing surgical intervention. So I think there are really some key takeaways from that, is that they're indicating from the data that's out there that PRP in general works, and that for players that had PRP plus rehab compared to rehab alone, that the players that had PRP had better return to play rates and shorter recovery times than those that did not have PRP. And then also, if you choose the right athlete, if you know the literature and you know, okay, I can choose a lower grade tear or a proximal base partial tear. If I do non-surgical management with PRP and rehab, those players can return to competition at rates comparable to those that undergo UCL reconstruction. And your return to play with that route is, we're looking at 3 to 4 months as opposed to 12 to 15 months with UCL reconstruction. So a big difference as far as return to play. So I think we just have to, PRP and rehab can be definitive. You just have to know the literature and choose the right athletes that it should work for. So all of these, we go through all of these papers in this paper. It's the one I mentioned before. So it was published in Current Sports Medicine Reports last year, and goes through really all the literature on orthobiologic treatment for throwing related injuries. And interestingly enough, really every paper that's in the literature for orthobiologics specific to throwing athletes, it's all UCL PRP studies. And so there's really nothing else that's out there. So if you're looking for a paper that goes through and breaks down all of the UCL PRP studies, this paper will do it. It was published in June of last year. This is just to say, as I mentioned before, this is just a study looking at magnetic resonance imaging predictors of failure of non-operative management of ulnar collateral ligament injuries. And really what this is going to say is that the distal tears do much worse with non-surgical management than the proximal tears do. And so I alluded to this earlier. And so a distal tear, I'm almost reflexively sending them to have surgery. Now, if this is a D3 pitcher that has a partial distal tear and is trying to finish his college career, then, you talk about pros and cons. They're not going to play pro ball. He wants to play his senior year. And if he has a distal tear, he can try PRP injection and rehab and see if you can get him back. And I have a couple that I've done that for, that they have gotten back and done pretty well. And so it's not to say that it's a slam dunk, they have to have surgery, but if you're talking about a pro guy or a higher level college pitcher that has aspirations to play in pro ball, then usually those distal tears are going to go straight to surgery. So again, the partial kind of mid substance to proximal tears, grade 1 or kind of grade 2 partial proximals, those can do well with non-surgical management with PRP and rehab. And again, this is just going back to that table from the Chris Ahmad paper that talks about the tear location on MRI, proximal, mid-substance, and distal, was it a grade 1, kind of low-grade partial, grade 2 partial, or grade 3 complete injury? And then is it a pitcher or a fielder? So we didn't really address that, but in a fielder, you can be a little bit more aggressive with non-surgical management than you can in a pitcher, just because they're not putting quite as much valgus stress on that arm. So if you look at proximal complete tear at the proximal aspect in a fielder, you can consider going with non-surgical management in that standpoint. And they even mentioned here with the distal tears, a grade 1 distal tear, even in a pitcher and a fielder, talking about non-surgical management. I think if we look at it that, in a pitcher, even if it's a grade 1 distal tear, a lot of those will go straight to surgery. So a couple things that are on here that I don't necessarily agree with just from clinical experience, but a good paper and good summary table overall to remind you if you need this in the future. So the take home with UCL injuries is that you're going to go the non-operative management PT with PRP route for partial tears, more at the mid substance and definitely at the proximal or humeral location. So in my opinion, if you have a baseball player that has a low grade partial proximal injury, that should be non-surgical management. It doesn't go that route now. A lot of players just reflexively now see any sort of UCL pathology and want UCL reconstruction. They're scared to go the non-surgical route because they don't want to waste 3 months and then have to have surgery. So I get that, but I think if you look at the data, it definitely can be definitive even for pitchers. Like I said, you can be more conservative for fielders versus pitchers, and non-op management I mentioned can definitely be definitive in the correct situation if you understand the literature and which of these tears should do well with non-surgical management. And that average return to play is going to be 12 weeks. And then when we talk about surgery, we're talking about those complete and high-grade tears, regardless of where the tear is, and then the distal ulnar origin tears. So just in the last few minutes, I'm not going to beat a dead horse with this. Like I mentioned before the talk started, I'm not a physical therapist. And so we'll talk about a few rehab considerations. And so what's important for rehab is the kinetic chain. And most of the people here probably know about the kinetic chain. So in a thrower, it's not about just rehabbing the arm. So you take force and transmit it through your body from the foot, through the leg, to the trunk, to the scapula, to the throwing arm. And if there's any breakdown along that kinetic chain, then that's going to predispose the throwing arm to injury. And so from a rehab standpoint, as you're in that initial phase that we kind of talked about, that initial 4 to 6 weeks where they're not doing baseball specific throwing activities, you're really focusing on their mechanics and their kinetic chain to see if there's any sort of breakdowns. Do they have weakness in their hips? Do they have weakness in their trunk? Do they have scapular dyskinesis? Those are things that need to be fixed in that time frame to try to prevent them from having injury in the future. So as I mentioned, I'll just kind of run through these. The kinetic chain in rehab, we're going to look at the core, lower extremity balance. We're going to look at the scapula. So you really want to focus on glute strength. And when pitchers are coming up and where they're balancing pitching, are their glutes strong to keep their pelvis square and straight so they're not coming forward or going backwards when they're coming up into their pitching stance. Also, and you can do that with dynamic tests, single leg squats, Y balance tests. We're also going to look at hip and trunk range of motion. We know, looking at the literature, if decreases in hip range of motion are associated with upper extremity injury in overhead throwing athletes. And so want to look at hip and trunk range of motion. And then overall, just making sure that they have a stable base with good strength in their trunk and lower extremity. And then also looking, you can't forget to look at the scapula, what we talked about, and what you'll see in the literature, and a good kind of concept they talked about is the scapula is kind of the force funnel, that force that's coming from your lower body through your trunk into the throwing arm. That all that force is kind of come through the scapula to come to the throwing arm. And so anything that's off with the scapular dyskinesis can throw that off. And so we really want to make sure in a throwing athlete that our scapular mechanics are on point. So here are just the phases of rehab. This comes from one of Kevin Wilkes' papers. With that said, we did a throwing athlete panel in January of 2022 as part of this series. Kevin Wilkes gave a talk on rehab considerations and throwing athletes. So if you're interested in this side of things, go back. He's one of the most well-known physical therapists that treats baseball athletes in the country, and he's a great speaker. So go look at his talk if you're interested in this. But from one of his papers, those phases, that initial kind of 1 to 2 weeks where you're just working on symptom management, reducing inflammation. Then you get into the intermediate and advanced strengthening phases where you're working on the kinetic chain, working on trunk and lower body and periscapular muscles and scapular mechanics. And then as you progress through that and you're doing well, then you'll return to your sport specific activities. So when a baseball player, you'd begin a throwing program at that time. This is just an example of the handout that I'll give. So the players that I use CLPRP for, it just walks them through. I mean, certainly this is not a one size fits all approach. We have to have an individualized component, but this just helps to walk it through. And it also helps the player to visualize kind of at what point are we doing certain things after we do this, because sometimes when they're getting the procedure done, it's hard for them to digest everything. So the handout just helps them visualize everything. So this is what I give to them, but we'll individualize it based on where they are in their season, when their season is starting, those sorts of things. So if you look at this now, the one that I have, it says initiate a throwing program at 10 to 12 weeks. Now, if we look at the literature, the return to play for full return to play to a game is 12 weeks. And so if I have a player that tears their UCL at the end of the season and they have the entire summer, so like a college player that has the entire summer to rest, then we'll do the PRP injection and they'll take the whole 3 months of summer and not throw and just work on their mechanics and work on getting strong. And they'll start a throwing program at 3 months. And so that can work. But I also have players that, we find a partial proximal UCL tear in November or December prior to the season starting in February in a college player. And we'll do a PRP injection and we'll start a throwing program dead on at 6 weeks for them, with the goal of them getting back to return to play at that 3 month mark. So I have a guy right now, a Division I player, had PRP in December. Our goal for him is to be back on the mound throwing in games at the end of March. Throwing programs, I mentioned them a lot here. There's no one perfect, one size fits all interval throwing program. Just as I was putting this together, actually just 2 days ago, this paper was published and from Mike Reinold again, where they put together an interval throwing program based upon workload data. So they made a throwing program back in 2002, Reinold and Wilk, and it's been used broadly across kind of the baseball medicine world as far as interval throwing programs to give to people. And it needed an update, and this updates that, brings in some workload data. So I think it's a really good throwing program. It's more specific to athletes after they have surgery because it's a really prolonged program, but I think the concepts in it are good. And so what I'll do with these is I'll kind of tailor them to my patients that I treat non-surgically and kind of shrink them down a little bit. So again, not a perfect throwing program out there. Find one that you like, and then talk to the athlete about what the goals are. And sometimes you'll tailor the throwing program in the office for them. but we also want to use the help of our physical therapists. And so what I'll say here is that, physical therapy is not all physical therapy is not equal, especially when it comes to baseball players. So in Atlanta, I have a group of 6 or 7 physical therapists that are very specific to baseball. They understand throwing mechanics, and athletes that work with them do better than athletes that go to kind of big box cookie cutter physical therapy. So all physical therapy is not created equal. So if you take care of a lot of throwers, find the baseball specific therapists in their area, because that you're going to do right by these kids, getting them in to physical therapists that really understand the demands of baseball and the mechanics of baseball. So this just shows they have a initial long toss, kind of flat ground progression. Once you complete that, then you'll get onto the mound. So for a position player, you just complete the long toss flat ground progression. For a pitcher, you're going to complete that first, and then you get onto the mound after that. So one of our baseball PTs put this together for me. It's just kind of his preferred rehab approach. And so minimum of 4 to 6 weeks. So you mentioned before, off of the offending activity, we really want to make sure they're pain-free with the radials before you start to progress them. You address any of the modifiable risk factors with rehab interventions. And so if you notice any shoulder, mainly total range of motion, so range of motion going in internal rotation and external rotation. If they have any total shoulder range of motion deficits, any deficits with elbow extension, try to work on those. You work on posture and scapular mechanics and scapular retraction, and also look for any hamstring and hip tightness, loss of hip external and internal rotation, and then that glute strength that we had talked about before, to really address those neuromuscular and postural deficits during that rehab phase. So in that 4 to 6 weeks before, or that period of time before they get back to their throwing program, again, addressing the mechanical deficits. And you want to work on a good functional movement screen, and also address their scapulothoracic movement too. So, you can't, like I mentioned before, it's not a one size fits all approach. You can't rely solely on the calendar. So when I give a patient a post-procedural rehab protocol, the therapist, I don't expect them to say, okay, we're at week 4, we can do this. We can't do this until week 8. Every athlete's going to be different and progress differently. And so you have to have a therapist that you're confident in, that is going to progress them from an individualized standpoint and use their expertise to help out the athlete the best way from that standpoint. And so really want in the rehab to look at the neuromuscular education, and mechanics is such a huge part before they get back to a throwing program, because this is a risk factor for injury. And if these aren't corrected, regardless if their pain gets better, they're going to go back to a throwing program and go back to baseball. If their neuromuscular and mechanical deficits aren't addressed, they're going to be right back in there with another injury. So that's all I got. This, again, we have a little arm care program on our website. You can get it if you need something easy to hand out to an athlete. And with that said, I really thank everyone for tuning in to this talk for a topic, again, that I'm really passionate about. And hopefully this helps for some of the throwing athletes that y'all are seeing in your clinic. And again, hopefully this whole series with the Fellows Online Lecture Series is helpful to all of y'all out there that are the fellows, or if you're preparing for boards. Hopefully we're doing right by you and giving you content that you feel like it's really helpful. So thanks again.
Thank you, Robbie. We don't have a lot of time, but there are a couple questions, so we'll just try to go through those. So the first question was, for the youth athlete with the medial epicondyle avulsion being managed conservatively with immobilization, would interval follow-up and imaging be on par with other long bone fractures, like every 7 to 10 days or every few weeks?
Yeah, I typically will do every few weeks with them. So we'll do kind of 2-week intervals. So maybe after you initially cast them, you'll have them come back at a week and do it, and then do 2-week intervals after that. Or if you're pretty comfortable with them, then I'll have them come back, we'll cast them, they'll come back in weeks, and we'll do 2 weeks, 4 weeks, 6 weeks. And then if things look pretty good at the 6-week interval, we'll take them out of the cast or the brace.
And then someone had a question about anterior elbow pain. I don't know that we have time to quite talk about that.
Yeah. So what was the question?
Just I can tell you kind of pathology it might be involved with anterior elbow pain.
Oh, so So I'll say in a throwing athlete, anterior elbow pain. Can you get some distal bicep stuff? Maybe, but typically in a throw, if we're talking about specific to throwing athletes, anterior kind of elbow forearm pain, you're thinking about more pronator syndrome, where when you're throwing the ball and pronating over and over again, you're going to pinch the median nerve between the pronator teres. So that would be something to keep in mind with kind of anterior elbow and forearm pain in a thrower.
And then the last one was, are you using PRP in the subacute, chronic, or re-injured post-reconstruction tears?
I think I've only done a post-reconstruction PRP injection on. No, I take that. I've done it on a couple different people. I was going to say only one, but then I thought just one that I did recently was on that. So yes, I have done that. And the progression back afterwards is exactly the same. And usually before I do that, though, we will clear that with their original surgeon from that they had the UCL reconstruction with. And so we will get the MRI, we'll have the surgeon look at it, make sure everyone's on the same page, and then do the PRP injection. So yes, we do that in certain situations if it's the right way to go based on kind of where the player is in their career and what the injury looks like on their MRI.
Perfect. Well, thanks for the talk. That was a great talk. One thing I will mention with anterior elbow pain as well, don't forget about just referred elbow joint pain. So things like OCDs, panners, things like that can obviously, kind of refer as anterior elbow pain coming from the joint itself. So if you haven't already, Andy has put the link in for this, the survey feedback. So if you would fill that out, that really helps us as we try to decide content going forward about things that y'all would like to see. So please fill that out. Andy also put in a plug if you haven't registered for the annual meeting. If you should go ahead and do that. If you're a fellow, you should definitely be attending the annual meeting. And then tune in next week because our lecture next week's Dr. Eric Laska is going to talk about adhesive capsulitis. So thanks for tuning in, everybody.
Thanks, everyone. Appreciate it.